How's the test? Fantastic.
You want the happy answer or the not so happy?
Wasn't that bad, right?
Yeah, because you're a doctor.
The strips that you had to figure out and identify?
Like this much of the text. Yeah.
Okay,
It's like
fine.
5 strips.
We appreciate your optimism.
So what was the hard or challenging or?
All the big words that we didn't know.
Don't let them fool you. It was easy test.
That's what I thought.
That first rhythm on there, that like everything was equal and looked normal, I couldn't figure out what it was. So just call it even.
I can't remember what the first rhythm you're talking about. Normal sinus.
Yeah.
Wait, it looked normal and you put AFib?
No, it's just good.
Okay.
Is there humor in there? You have to explain your joke.
Roughly what chapter we on?
This is 7. We're going to do 7 first and then 6.
That's gonna slip off.
I apologize for my voice.
Not bad.
At times it might sound like a pubescent adolescent. Get a little squeaky. But let's jump right into it. Because your guys' brains are ready, right? After being fried on the test. All right. So you guys are familiar with the AV junction. You guys know where the AV node is, right? So if there's a delay or interruption of that impulse, the connection in the AV node, the bundle of His. Now it talks about the His Purkinje system. You guys don't really need to know that. It's just AV node, then bundle of His, and then bundle branches, right? The dysrhythmia is called an atrioventricular block. And that's the AV blocks, and that's what we're going to be talking about. So the classification of AV blocks, they have a little bit of semantics in here, and I'll try to clarify that a little bit. So traditionally, they are classified by 2 reasons or categories according to the degree and the site of the block. Now here, the PR interval is the key to differentiating the type of AV block. And the type is the same, that's synonymous with degree in that previous slide. So don't get confused by semantics and just wording. Type is the same thing as degree, and the site is the same thing as level. All right? So the key to differentiating the level or type of the block is the width of the QRS complex, which becomes evident in the second degree AV blocks. There's second degree type 1 and 2, and we'll talk about that, but they have one is narrow and one has a wide QRS complex, and that's how you differentiate that one. Let's see. So all of them are incomplete blocks except for third degree AV block. All right, which means that in the conduction system, there's still an impulse in first degree in both types of second degree blocks. There's still an impulse sneaking through, right? Because there's only a dropped beat sometimes. But for the rest of the time, there's this regular rhythm going on because there's impulses going through. And then every now and then they're blocked. And then there's no impulse. We'll talk about that. In third degree AV block, there's no connection between atria and ventricle. It's a complete block. All right, so name of the block. The first degree AV block is in the AV node. That comes from the AV node when there's this incomplete block in the AV node. Also second degree AV block type 1. And then third degree AV block can come from, at least that block can be in any of those sites. A third degree AV block can be in the AV node, can be in the bundle of His, can be in the bundle branches. As long as there's a complete block in any of those sites, then it's a third degree block, okay? Because third degree is a complete block. Now second degree, first degree is always from the AV node, right? The second degree AV block can be at the AV node or can be infranodal underneath the AV node in the bundle of His or in the bundle branches. If it's a type 1, it's in the AV node. If it's type 2, it's going to be lower in that conduction system, below the AV node in the bundle of His or bundle branches, okay? And that's why a type 2, because it's infranodal, has a wide QRS complex. A type 1, because it's at the AV node, still has a normal QRS complex because the conduction going through, or at least getting through, still creates a normal conduction in the ventricles and a normal width of the QRS. All right? We'll talk about that more.
Did you say type 1 is?
Has a normal QRS, at least width. What's that?
Internal, you said?
And that's in the AV node, yeah.
So second degree type 2.
Second degree type 2 is lower, so it creates this delay in the ventricles and creates a wide QRS complex.
It's never in the AV node.
The type 2 is not, no.
Is that where you sort of see like left and right bundle branch blocks? You have one depolarizing it moves a certain bit.
So a left or a right bundle branch block has a wide QRS complex, right? And we haven't specifically gone over bundle branch blocks, have we? I think we are going to do that in the next lecture. Go over VTAC, we go over VFib. I think we covered bundle branches. I can't quite remember. But the whole idea behind a bundle branch blocks is you know where the bundle branches are, right? It goes bundle of His, then bundle branches down through the septum, and then it spreads out to the Purkinje fibers. If there's a block in one of those bundle branches, the other one's still getting through, but it's delayed because it's only getting through on one side, and then it has to be through the muscular conduction system to get to the other side, so it's a wide QRS complex with either a right bundle branch block or a left bundle branch block. If you block both of them, then there's no conduction down through the ventricles, and that becomes what? A complete bundle branch block. So anytime you have somebody that has like a right bundle and then like a left anterior fascicular block, they're on their, which is half of a left bundle branch block, they're on their way, means that there is heart disease in that blood vessel feeding those bundle branches, and eventually that blood system is going to create a complete bundle branch block. We just don't know when that's going to happen. So we can tell a patient, hey, eventually you're going to get this, and it can be life-threatening. So if you feel lightheaded, faint, whatever, you need to come in.
So that third degree AV block in the bundle branches, that's only called that if both bundle branches are blocked.
Right.
One's still going and wouldn't call it third degree.
Then it's not a third degree, right? Because it's not completely blocked. The other branch is still getting signal through. All right. So this kind of gives you, at least for the site or location, you've got the AV node, that's where your first degree happens. That's where your second degree type 1 happens. Complete bundle branch block, which is third degree, can happen at any of the sites as long as it's completely blocked. Bundle of His, that's second degree type 2 or complete. Bundle branches, second degree type 2 or complete. All right, so anything below the AV node, second degree type 2 or complete in location. So clinical significance of this is obviously, depending on the severity of the bundle branch block, can cause significant issues. If you have a complete bundle branch block, what happens, or what is the automaticity of the heart rate then? What does it become? Yeah, it relies on ventricles, Purkinje fibers. How fast is that? 20 to 40. They might be hanging on if it's around 40, right? They might just be feeling incredibly faint, tired, lightheaded, a little confused. If that heart rate is more at the 20, then what's happening? Right. then they go into cardiac arrest really quickly, right? Because they're not perfusing anything. So somebody that suddenly goes into that and their automaticity is low, that can be significantly life-threatening. So you guys could come on a patient that's out, that has a heart rate in the 20s, and if you get a strip on that and recognize that it's a third-degree AV block, all I have to do is pace them. Boom, they wake up. All right, that's why it's significant to be able to recognize those things.
How do they go and fix the block in the hospital?
They don't. They get a pacemaker. All right. So we talked about that. It's significant with the degree, what kind of block it is, what the rate of the escape pacemaker is, meaning the automaticity that then takes over, and then the patient's response to that rate. First degree AV block. So how do we recognize it? So everything with a first degree AV block is normal in the QRS complex, PQRS complex, except for the PR interval. What happens to the PR interval? Good. So the PR interval is more than what? 0.2, right. But everything else is normal. And there's no skipped beats. So first degree AV block, fairly asymptomatic, right? Patient can live their whole life with a first degree AV block and not have any problems. So even though it's called an AV block, like I was saying before, it's not complete, right? There's still an impulse that's getting through. Sinus beats are being conducted. Let's see. So the impulses are delayed because it's an incomplete block, and that's what creates that longer PR interval. But once it gets past that point, it still goes down to the QRS, and the QRS looks normal, right? Because that conduction system then goes through the QRS normally. All right. So do you guys recognize that? Looking at that strip, everything looks normal. That PR interval is wide, right? Now, on your guys' strips you get from the machines, they usually would automatically say PR interval wide, likely first degree AV block. What's the PR interval here? 1, 2, 3, 4, 5, 6, 7, 8 boxes. Eight times what? 0.04? What are you doing? Seriously?
What? It wasn't full when I started. Prepared for hibernation.
That is one of the strangest things I've ever seen
You didn't do that in med
during a lecture. I mean, I've been part of a lot of lectures with a lot of students. My med school class had 210 students in it.
And nobody was smart enough to bring their own ice cream.
Nobody had ice cream during a lecture.
You mean in the middle of winter time?
It's just, although your choice of ice cream is at Tillamook,
Yeah.
it's good stuff. I don't know about Rocky Road, but Tillamook is not bad. All right. So the P wave looks normal, right? Everything else is normal looking except for that PR interval. And that PR interval will be abnormal in all of the leads, as long as you can identify where the P wave is, right? But it's most recognizable again in 2, 3, and AVF, because lead 2 and 3 are those leads where you can really, or at least you should be able to see P waves, as well as V2 when we talk about full 12 lead EKGs. So yeah, the PR interval is prolonged. This is just a repeat of the same material. So what causes it? Can be normal. Can also be because of ischemia, meaning lack of blood flow to that area, so it creates damage to the conduction system in the nerve, and it becomes kind of an incomplete conduction system and delays that conduction, increasing the PR interval. Medications can cause it. Rheumatic heart disease can cause it, which is why we give strep throat antibiotics, although most evidence shows that that's probably not needed, especially in adults. Adults really should never need antibiotics for strep throat. We give it prophylactically in kids, but most evidence shows that it really doesn't serve too much of a purpose, at least from a resource standpoint, because the odds of getting rheumatic fever causing rheumatic heart disease are so low that the risk of the antibiotic itself is greater than the benefit. Well, a number of things. I mean, antibiotics can cause Steve Johnson syndrome, can cause anaphylaxis, can cause, C. diff. There's a lot of negative effects from antibiotics, resistance in general, because we give antibiotics out like candy for strep throat, right? Because patients expect that. And if they come in and the doctor doesn't give them antibiotics and tries to explain to them, evidence shows that really don't need this and there's no reason for you to be getting this, especially if they have a sick kid with strep throat and they're like, what? And they leave the doctor's office and go, that doctor didn't do anything for me. And they go to the next doctor or the next emergency department or the next urgent care until somebody gives it to them. And everybody gives it to them because then they get bad reviews if they don't and blah, blah, blah. So you got all these patients getting antibiotics when they really shouldn't be.
Did your wife say something to that?
Yeah, yeah. My wife says the same thing about ear infections. And did those antibiotics do anything for her ear infection? Absolutely not. Yeah. And she even told me, like, the day after she kind of calmed down and she was taking her antibiotics, and she was like, these aren't going to really help me, are they? I'm like, nope. But, and side note for strep, so even if they actually do have strep throat and they get the correct antibiotics, which again are not needed, the antibiotic only decreases the symptoms of strep throat by 12 hours. So if they were going to be sick for 7 days from strep throat, with the antibiotics, they'll be sick for 6.5 days. So was there really a benefit to that? Antibiotics made me better. No, not really. All right. Side note, I shouldn't get on those. You guys should stop me when I get on those rants. All right, so first degree AV block, what do you do about it? Well, there's usually no symptoms. If it's in the setting of acute MI, meaning if they have new increased PR interval, they also have ST elevations, where do you think those ST elevations will be? If there's a new type 1, what blood supply feeds the AV node? Right coronary artery. So what kind of MI would you have?
Right.
So inferior, yeah. So the RCA affects so you'd have an inferior, maybe inferior posterior MI, because that's what the RCA feeds, right? Second degree AV block. So again, this is when some but not all of the impulses are blocked. Because the SA node generates impulses in a normal manner, the P waves occur regularly across the rhythm strip. Right, so the SA node is continuing to fire at its automaticity rate, right? Regardless of the block, even though some of them are being blocked and some of them aren't, the SA node is just continuing to fire those. So there's going to be continual P waves in a regular rate, but not every P wave will have a QRS, meaning that there'll be a skipped beat in second degree AV block. So above the bundle of His, meaning in the AV node, will be type 1. Below the bundle of His, or in the bundle of His, will be type 2. We talked about that. So second degree type 1. This is so it appears on the EKG as a P wave with no QRS after it. Then the cycle begins again. Repetition of pattern is called grouped beating.
Now, I've got a question for type 1.
Uh-huh.
Is it just because it's taken longer to depolarize, or it's not gone through its refractory period? That's why you have the skip beat, or why do you have that mark?
No, it's because of the severity of the damage to the nerve and how the impulses are getting through, meaning that it's kind of just hanging on a thread a little bit, where the impulse will get through and it'll look normal, and then the next one will get through but it'll be a little bit longer. The next one will get through and it'll be a little bit longer until it's not enough and no QRS complex doesn't get through, and there's a skipped beat. There's no QRS complex. Now, if you get into the nitty gritty of why does it keep getting longer and longer from a physiologic standpoint, I don't know. I mean, you'd have to ask like cardiologist researchers. If you ask your normal cardiologist doc, they probably wouldn't know either. But yeah, it might have to do something with how the P wave repolarizes, and finally, as it's repolarizing, it's not able to get completely through. I don't know. So there's an example. So if you look at this one first, it's P wave with a normal PR interval, right? The next one is longer, and that becomes an abnormal PR interval. The next one's even longer. That's a really wide PR interval. And then the next one, the P wave, beats almost right after the T wave, and there's no QRS.
So
Skipped beat.
we're getting essentially where the top and the bottom are working independently of each other.
No, they're not working independently because the bottom is not firing by itself. The QRS is always firing with a P wave or after a P wave. It's just that in this circumstance, the P wave's still there, but the QRS doesn't fire. If a QRS is going to fire, it's still going to fire after a P wave or because of the signal coming down from the atrium. So they're not independently. Independent is only with a complete heart block, 3rd degree. Okay? With these heart blocks, it's just that signal is getting worse and worse and worse until it drops. And there's no beat. And then it starts again. And then you'll see the same pattern. Normal PRI, longer and longer, and then it'll skip again.
But that's not, like, the P wave's not regular.
P wave's regular.
It doesn't look
If
like-
you get out your calibers, those things will be the same every time. SA node is going regularly every time.
That's 16.
Yep.
Are they typically in that pattern too?
What do you mean? Like 3 and then a drop?
Yeah,
No.
okay, so just depending on.
You'll just have to pay attention to the PRI. It might take 5 before it's dropped, but then you'll see a pattern of it's getting longer and longer and longer until it's dropped. All right. But if you see regularly dropped beats in a strip, then you automatically go, I'm looking at the PRI. I'm looking at the P wave to see, is every QRS fired after a P wave? If the answer is yes, and it's not a complete heart block, all right? And then looking at the PRI and how it's widened. If there's no skipped beat and the PRI is widened, that's a type 1, right? Or sorry, not a type 1, a 1st degree. If the PRI is widened and it's getting longer and longer, that's a 2nd degree type 1. We'll talk about the difference between type 2 here in a second. So yeah, the PRI interval lengthens with each cycle until the P wave's there without a QRS. And in this, because it's a 2nd degree type 1, where's the block coming from? The location is above the His. It's in the AV node, so the QRS is what? Normal in appearance. That's another hint, meaning the difference between a 2nd degree type 1 and a type 2. Type 1 normal QRS, PRI slowly lengthens until there's a drop beat. So how do you recognize it? Atrial rate is faster than the ventricular rate. I think you can kind of recognize that just just by the eyeball that there's more P waves than QRSs. And the ventricular rate is irregular because it's having dropped beats. And it doesn't necessarily always have to be, it's not always in a pattern, meaning if it's 3 with the PRA slowly getting bigger and then dropped, the next one could be 4 and then dropped. The next one could be 2 and then dropped. The ventricular rate is irregular, just depending on how that impulse is getting through. And on each beat might be a little bit different in how it's getting through. So that ventricular rate is going to be irregular. It's not always going to be a pattern.
Real quick, it said that repetition of the pattern is supposed to be creating, but this is going to be something that continues to happen until the block is pushed, right?
Let's see, where's that?
It was a couple slides.
Oh, the grouped beating.
Yeah.
Let's see, what are we talking about
Here we go.
What's the joke here?
It just reminds me of Rodney King. So it's-
The teacher, Laban, said, "Group meeting, I love that."
What? Oh, goodness. You don't have to worry about that, John. If I'll look over the question, if there's a question on grouped beating, then we'll throw it out. Because that holds no significance on what you need to know and how you classify or anything like that. Rodney King. All right. So what causes it? Again, so increased parasympathetic tone, increased vagus nerve, right? Stimulation, which usually happens because the opposite is blocked, right? Ischemic heart disease, effects of drugs. There's DIG again. Beta blockers, verapamil. And then your inferior wall MIs, like I was talking about. With type 1, patients are usually asymptomatic. So first degree and second degree type 1 are usually not dangerous, okay, in and of themselves. The rhythms themselves aren't going to cause any kind of fatality. Of course, what caused it, if it was a heart attack, certainly could, but the rhythm itself is not dangerous. If the patient's symptomatic, however, because maybe they're having a heart attack or something else, then treatment is obviously required. So if the heart rate is slow and they have signs of symptoms, because of that, you certainly could try atropine or temporary pacing. Now with these two types of blocks, usually you don't get that slow heart rate because you're still getting stuff from the SA node. So it's usually not so slow that it's going to cause symptoms. But certainly if it does, you can try to speed it up. You can try temporary pacing. What does atropine do? What's it do? What? How does it increase heart rate? What does it act on? What's that? Okay. It blocks the parasympathetic. So what is it? What parasympathetic is what neurotransmitter again? Acetylcholine. So it blocks acetylcholine at the receptor site. Blocks the parasympathetic system, and then what takes over? The sympathetic. So it doesn't actively stimulate the sympathetic, it just blocks the parasympathetic. All right?
But if the conduction process has a problem, how is that really going to help us?
You're trying to increase the SA node, and if you're increasing the SA node and those beats, at least most of those beats are getting through, then you'll increase cardiac output, right? And if you get any of these blocks with an MI, obviously you want to watch this patient closely, watch their rhythm closely, get repeat EKGs, because likely that heart attack is continually getting worse, and that asymptomatic block will turn into a symptomatic block quickly. Does that make sense?
So you'd still be thinking of your heart attack. You did have elevation.
All right, second degree AV block type 2. Again, at or below the bundle of His. Or excuse me. So it's below the AV node. Below the AV node. So again, P waves are occurring at regular intervals. The SA node's not affected, it's still going. The impulses generated by the SA node are conducted to the ventricles at the same rate until an impulse is suddenly blocked. So because it's after the AV node, it's getting through, and the block is more at the ventricular level because it's at the bundle of His or below. So the P wave or the PRI interval doesn't change. PRI interval is increased, but it doesn't change. It stays the same until there's a block, until there's no QRS after it. So do you see that? You still have P waves, boom, 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 boom. The PRI doesn't have to even be wide. Then you have a drop beat. No QRS, no QRS. Conduction is not getting through. Now, I would say that this strip is a little bit abnormal in that there are 2 in a row that are blocked. Usually, you don't always see that, but you certainly can.
So the second degree is kind of a temporary thing, because it's only one.
Well, it will continually have blocks. So you'll show regular beats and then block, regular block. So you'll continually have blocks. There's just not an increasing PRI. All right. So that's the difference between type 1 and type 2. And look at the QRS. How's that look? It's wide. So type 2, because it's below that AV node and it's more in the ventricular conduction system, becomes delayed, creating a wide QRS.
With the second degree type 2, is it a regular block, but you can tell where the block is going to be each time, or
No, not always.
irregular?
It's still irregular.
So that quick depolarization down is from the other branch of depolarizing the muscle, and that slow, kind of wider rate is from the cell-to-cell electrical connection going through
So
there.
yeah, the wide QRS is from the cell to cell.
But you have the initial, the good branch. Or
What do you mean the initial steep one? Like that initial, I mean, because you have an R wave and an S wave in this.
so the S wave
An
is
RS. I mean, you could say, yeah, the R is fairly fast and then it becomes delayed. I mean, you're not going to be asked about that nitty gritty. Overall, you just need to look at the whole QRS complex as a whole and say it's wide. All right, it's above 0.12. If it's between 0.1 and 0.12, that's incomplete. That's when we're talking about bundle branch blocks.
I guess I'm confused. I thought you said that the PRI will have no change, but there will be an increased P interval or segment. However, PR.
Sometimes. So the PRI can sometimes be widened. In this example, the PRI looks pretty neat. Let's see. 1, 2, 3, 4, 4.5. PRI is pretty normal.
So why would, in that big space of missed beats, why don't we see the Purkinje's pick up and pace like that?
it might not be long enough, or there is still, the SA node is still firing, and it is incomplete, so you're not getting those escape beats, right? You don't always have escape beats. Sometimes you'll have arrest for 5 seconds, and there'll never be an escape beat. So that's not like automatic. If there's a period of arrest, you're going to get an escape beat. That's not automatic. It's just that you might have one.
So it looked like ABC mixed somewhere in there.
If you had an escape beat?
Yeah.
Yes, but a ventricular escape beat is more at the end of the arrest, whereas a atrial escape beat is going to be pretty close to the beginning of that arrest, right? We'll talk about that in the next lecture too. All right, so the P waves, normal size and shape, and then some of the P waves are not followed by a QRS. The PRA interval is usually within normal. It can be normal or it can be a little bit prolonged, but it's the same. All right. So does that make sense in differentiating second degree type 1 and type 2?
I guess I don't really see the difference in those two that they've showed us. How it's the difference between above or below the node.
Want to say what?
Why does that tell me that that's subnodal?
Because you have a wide QRS. And because the PRI is relatively normal. So everything's going on. The conduction system looks pretty good through the atria. And when it gets past the atria and starts to get towards the ventricles, that's when your conduction system is crap and becomes delayed
Okay,
with a wide
that
QRS.
makes sense.
So can you have these that are kind of near the apex of the heart too? Or are they always just right below?
You mean type 2s?
Yeah.
If you have them towards the apex, that'll be more like in the Purkinje system. And then you might have a little bit of a wide QRS, a little bit of a delay, but they're not going to be AV blocks. All right. So type 2, because they are below the AV node, this is bundle branch and His. It's going to be more anterior wall MIs, meaning left coronary artery disease, right? So when you have these, you're going to have significant slowing of the heart, right? Because the only system that's going to take over and getting that conduction is Purkinje. So if you've got significant or frequent blocks, then your heart rate can be significantly slower. And if you have a type 2, like I was telling one of you guys that asked, the only thing that can really fix the problem is a pacemaker. So second degree AV block with a 2-to-1 conduction. We'll talk about that 2-to-1 AV block. And the reason why it's important is because it's hard, or it's easy to confuse 2-to-1 AV blocks with a complete heart block. And I'll show you, we'll talk about the differences. So the P waves are conducted consecutively. The problem with the 2-to-1 is you can't always recognize them. These strips do not give you an example of 2-to-1. I don't know why they put these strips on this slide. These are the two. I mean, this is a type 1. This is a type 2, both second degree. Type 1, type 2, right? They're the same strips as we saw before. I don't know why they put these on the 2-to-1, because these are obviously not 2-to-1s. So you can kind of disregard those strips as examples of the 2-to-1. But there'll be a better example here coming up. So two P waves for every 1 QRS, meaning that there's every other beat is a skipped beat, right? So how do you determine between a type 1 and a type 2? If you've got a 2-to-1 AV block, you look at the QRS complex. If QRS is normal, then it's a type 1. If QRS is wide, it's type 2. All right, so here's an example of a 2-to-1 AV block. Now, this is a normal QRS, right? So what type is it? Type 1. Now, would you ever be able to tell it's a type 1 other than looking at the QRS? I mean, we normally tell if it's type 1 by looking at the what? The PR interval, and it's slowly getting longer. But if it's skipped every other time, then you can never see that pattern, right? You'll never see it start to get longer because it's skipped every other time. So otherwise, looking at that normally, you'd be like, oh, that's a type 2 because the PR interval looks normal in the ones that the QRS is following it. But no, it's a type 1. It's just that you're not seeing the pattern because every other is skipped. How you can tell is that QRS and the QRS complex. Is it narrow or wide?
So it'd be more appropriate to call that a secondary type 2 or
This one,
call the 2-to-1 block?
it's a second degree type 1 AV block, 2-to-1.
So the 2-to-1 is going to be
Yeah, 2-to-1 is just a type of second degree AV block, meaning just the frequency of it being skipped. The reason why it's significant is because it's often difficult to differentiate.
Why would it be a type 1 instead of a type 2? Because you still dropping the beat, essentially, which is happening at the 2-1, right?
Wait, why wouldn't it be what?
A type 2, a second degree type 2 block.
Because where is it happening?
It's happening right after the T each time. But you get
But look at the QRS complex. It's normal, right?
right.
So if the QRS complex is widening, that means that the site of injury is below the AV node. We know that this is not below the AV node because the QRS is normal. So it's at the AV node, which makes it a type 1. Does that make sense? So here's an example of a 2-to-1 type 2. Why is it a type 2? Why QRS? Do you guys see the P wave buried in the T?
I can assume that
That's a P wave. And these things are just marching up. Same every time. What else is going on there? ST elevation, huh? Depending on which lead that is, and if they have also have like a left bundle branch block, then you can decide on if that's actually ischemia or not. But in this case, you have to assume it is until proven otherwise. So this is just kind of more definition. Do you guys have any questions on differentiating between the two?
Maybe this is backing up too far on that last slide. How come it's such a short R wave?
It depends on which lead it's in.
So we're going,
I mean, this certainly could be lead 2. If you have a small R wave and most of your amplitude is negative in lead 2, that means what?
go away from it, which is an extreme axis deviation. Right?
It's an axis deviation, right? So we talked about axis, right? We drew that, the circle, the heart on it, and where the leads are. You guys want me to draw that again?
But that's
Or
what
do you
I'm saying.
understand?
That's kind of going the wrong way.
So if you've got injury to the conduction system and you've got the impulse going the opposite way, creating a negative deflection at lead 2, then most of your amplitude is going to be a negative deflection. That means that this person has a type 2 or second degree type 2 AV block, but also if this is lead 2 and you have negative deflection where normally you would have positive deflection, it means that you have left axis deviation, likely a left anterior fascicular block as well, meaning going towards a left bundle branch block. Or maybe that patient has a full left bundle branch block and now has an AV block on top of it. That's why you're going to have that huge deflection on the S-wave. You don't really need to know why that is until we talk about full 12 lead EKGs and you start looking at which lead you're studying and why the QRS complex looks different in that lead. Is Doug doing like some testing or something? Okay. Like, now what does that mean? Seeing how you guys are doing?
Just goes over how module 1 was.
Yeah. Let's see. All right. Causes treatment for 2 to 1 is the same as type 1 and type 2 respectively, right? Because all they are is type 1 and type 2 blocks. So this gives you a good slide of the 3. Do you guys want me to go through that? So you're looking at this lead. You say, okay, going through, it looks like there's a skipped beat because the P waves are still going. I got a P wave and no QRS, and there's a skipped beat. Now I'm looking at the PR intervals, and I can see this PR interval. It's widening. It's getting even wider. So that is a second degree type 1, right? So a first degree AV block would look like what?
Just constant.
Just a constant wide PRI. Are you gonna have skip beats? No, you really don't. If there's a skipped beat, then what is that? Or second degree type 2, right? So second degree type 2, you got the same PRI intervals. Look at it the same way. You're looking at the strip and you're going, well, I got P waves with no QRSs. So there's an incomplete block here somewhere. It's an AV block. I'll look at the PRIs. They look the same. And then you got skipped beats. Second degree type 2. You've got a 2 to 1 block. Well, how do I figure out if this is type 1 or type 2? I mean, you could look at the PRIs real quick and be like, well, it's long. So that might be more of a second degree type 1, but second degree type 2 can also be prolonged, right? The big differentiating factor is the QRS. Now, it's saying that this is a second degree 2 to 1 conduction. Okay. It doesn't say if it's type 1 or type 2. Which one is it?
Normal QRS.
Okay. QRS is normal. It's type 1. Third degree AV block. Third degree is what kind of block? Incomplete or complete? Complete AV block. So what do you suspect your strip will look like? Well, you have QRSs after P waves. They're going to be dissociated. So you might randomly have a QRS that looks like it's after a P wave, right? But for the most part, they both beat regularly but independently. You have to march them out. Meaning you have to identify where the P wave is and see where it marches out. Sometimes that P wave is going to be buried in the QRS. Sometimes it'll be in the T wave. So you might not always be able to find it. You need to try to figure out, well, if that QRS looks a little bit different than the previous one, that's probably because the P wave is buried in there somewhere. And you can start to march it out. All right? So that block, as long as it's a complete block, can happen anywhere in that system, right? So this is a third degree with an inferior MI. So the block is likely above the bundle of His. Because why? The QRS looks, relatively normal. It's not super wide. So 1, 2, 3. The problem is sometimes you'll count boxes all the way to that what looks like a J point, but that's not necessarily. This is ST segment, right? You have to figure out, well, which one am I actually looking at? Because the P wave is continually. Let's see if we can identify at least two P waves. That one's probably buried, so you got those two P waves, and you can identify them as P waves, right? So then you want to march it out. That P wave is buried right there. That P wave is right after the T wave there. On different sides.
I have a question.
Yep.
I don't know if this goes with this, but you'll get some variancy with reaching it out. How much is considered, beyond?
You mean variance in the distance?
Yeah.
You shouldn't have more than like 1 or 2 boxes. But like I said, sometimes it's hard to identify them because they'll be buried, right?
Yeah.
So you take a distance where you know where the P wave is, and then you can march it out there.
So you have different rates?
With a complete?
Yeah.
Yeah, you'll have different rates, but they'll all be slow. I mean, I've had some, normally your complete heart blocks are unstable because those rates are down in the 20s and 30s. If they're holding on at 40-ish, or if they're on, certain medications or whatever, it's keeping their heart rate a little bit higher and they're in the 40s, sometimes they can, they just feel tired, they keep getting lightheaded, they're passing out a couple times, they finally come in and be like, I don't know what's going on, I felt like crap over the last 2 weeks. Like, dude, you've got a complete heart block. You should be dead. What do you do with a complete heart block?
I get a pacemaker.
Okay, yeah, you can do a pacemaker.
How much that's they end up getting?
Yeah, I mean, you got to pace them. If they're unstable, if their blood pressure's iffy, whatever, you transcutaneous pacing.
So, how does that for the review thing? What's the operator?
Yeah.
The third degree.
Hold on, we'll go with Alec first.
With the third degree complete block, is it generally slower or faster than 40? Because that says
That is, that's if it's junctional, and we'll talk about that. That's a different kind of a block. But and we'll talk about that. I can see how this slide would be a little bit confusing. Generally, a complete heart block is slow, less than 40.
Are they getting the inferior MI just based on the?
Depends on which lead that is, but yeah. And if you have ST segment depression in inferior leads, then it's a fairly old MI. Because normally with an acute MI, you'd have elevations, right? If that's inferior leads, I don't know which lead they're putting on them.
Elevation, sound,
Depression and others.
This rhythm check doesn't tell us that there's an inferior. It's just the opposite. They're just saying this person has an inferior.
Yeah, exactly. This person has an inferior MI. This is a rhythm strip, but you wouldn't know that they have an inferior MI by looking at that rhythm strip. All right, I wouldn't.
yes.
Oh, so by the way, I was realizing that.
did you read the online tutorial?
So if you have a complete heart block that's above the bundle of His, then it's not a ventricular problem. That complete block is above in the atrium. So you can still have, a stable rhythm, and the heart rate can be functional. We'll talk about this a little bit. So this is a third degree AV block with an anterior MI. Again, you can't look at that strip and say that's anterior. It all depends on which lead it's in. So don't necessarily worry about that. But it's just saying that an inferior MI is going to affect different parts of the conduction system than an anterior MI, right? If you have a third degree AV block with an inferior MI, likely that's going to be above the bundle of His, if that's where that blood supply goes. All right. If you have an anterior third degree block with an anterior MI, it's likely blocking or the damage is below the AV node.
I thought with third degree blocks, you don't have any QRS. Sure.
You still have QRS complexes. They're just not associated with the P waves.
So they can still.
They're independent because the ventricular automaticity takes over, right? If it's blocked, then the next level lower takes over. And that's why it's so slow. That's why it's bradycardic. It's because the ventricular automaticity is slow, right? Does that make sense?
Yeah, I thought I read somewhere that it was QRS.
No, if you had a third degree AV block with no QRS complexes, what's that?
Yeah,
That's asystole.
That looks really clean to be a ventricular beat, though.
Let's
Just me. From your experience.
1, 2, 30, or
So 0.16, it's wide, but it's not super wide. If you count out the boxes and see where the QRS complexes is, because yeah, if it's lower, you should have a wide complex QRS.
there's nodes on the computer.
You know what my screen's like.
So does that make sense with the location of where that block is? If that block's higher, the QRS is going to be normal width. Heart rate might still be faster than 40. If that block is lower, where normally when we see complete heart blocks, they are lower blocks and you're significantly bradycardic, wide QRS.
The other point is that you know that it's below the AV node, right?
And that's with second degree and third degree, right? Now, I have never been asked a question in medical school or anywhere else of where in the conduction system do you think this injury occurred? At least I don't remember. So that question will not be asked of you. Okay?
Focus that it's below the nose.
So I will be reading the test, and if that question's on there, I'll throw it up. So HO rate's faster than ventricular rate because the ventricular rate is taking over at its own automaticity and it's going to be slower, right? Both of them are going to be regular. SA node is going to be firing with regular P waves, and then the ventricular automaticity is going to take over, and that's going to be irregular in comparison to itself, not each other, because they're independent, right? All right. Light bulb, Trevor?
Go
So if it's with an inferior MI, oftentimes those complete heart blocks will resolve on their own. Sometimes if you've got an inferior MI with complete heart block, instead of just throwing a pacemaker in, sometimes they'll wait. Depends on how the cardiologist is feeling. Oftentimes, they'll just throw the pacemaker in so the patient doesn't have to sit around, and they don't have to take care of them for a week. But if it's an anterior MI, that complete heart block is not going to resolve likely, and it requires pacemaker. But really, from your guys' perspective, if it's a second degree type 2 or a third degree, definitive treatment is pacemaker. So this is one of the reasons why location can be important. If the QRS is narrow in a third degree and the patient's symptomatic, you can give atropine. What does atropine do again? Blocks the parasympathetic so the sympathetic can take over. All right. If the QRS is wide and that block is lower in the conduction system, atropine's not going to help.
So would the atropine act on the junction to the junctional space up? That's why that would help?
Right.
But it doesn't work on the ventricular.
But it won't work on, because those nerve connections, the sympathetic nerve connections aren't at the ventricles. They're all in the atrium, right? So if that block is a little bit higher, but you still got impulses to that higher portion, those impulses can get down, and the atropine can help within a third degree AV block that has a narrow or has a normal looking QRS complex, meaning that it's higher in location. Atropine won't do anything if the block's lower, right?
So I like to beat pump.
So just to clarify, so sympathetic nerve system will, SA node and the AV node, and speed both of those rhythms up.
Yep.
That doesn't affect the ventricular.
Right. Below the AV node, meaning bundle of His, and down, it won't affect.
So like with VTAC, there's nothing. That's the reason why we can't give anything that would help VTAC other than electricity, because there's not.
Yeah, atropine won't help. VFib, VTAC.
Well, I mean, like,
well,
just
none
slow
of those,
it
but
down even, but
right.
because there's nothing.
Right. Medications aren't going to necessarily do a whole lot for those, right?
So, because I take the first bullet point to be that we're in a third degree block, which is complete, which means it's subnodal, right? It's below the AV node.
It can be at the AV node as well. A third degree complete can
But
be
that
at the
still
AV
means
node.
that atropine would have no effect on it, wouldn't it? Because if that only gets down to the AV node.
And the AV node is blocked. Well, it depends. Atropine can have an effect. It can depend on where at that AV node, because the AV node isn't just like a black and white line, right? It's a cell, and depending on where that block is, atropine can still have an effect depending on if those connections are going below where that block is. Now, it might not. If the block is at the AV node, but like right at the border of the bundle of His, then those effects, that sympathetic drive probably is not going to do anything.
Is there any negative to the atropine of a wide complex?
No, it's just not going to do anything. So yeah, I mean, most of the time, you'll see these cases and they'll try atropine. So from a clinical perspective, meaning in the bus on as paramedics, giving atropine is not going to cause any negative effects. So yeah, if you can't remember, oh shoot, is this is this higher in the conduction system, lower in the conduction system? It doesn't really matter. You could try atropine and see if it helps, right? However, the point is that you want to get that patient paced with normal, or not normal, but better cardiac output on a quicker, right? So you don't always want to waste time trying to get them atropine. Just throw the pads on there and start pacing them. Now, what do you want to do before you start pacing them, or as you start pacing them? Give them a little bit of pain medicine before you start electrocuting them, right? I had a patient in residency, and my attending started pacing the patient right away because the patient was unstable and unconscious because their heart rate was in the 20s. And as soon as we started pacing and there was capture, patient woke up, completely perfused and normal, like GCS 15, but in a lot of pain, right? What are you doing to me? What are you doing to me? And then my attending freaked out and turned off the pacing machine. And then what did the patient do?
Stop talking.
Right? So, hey, why don't we give this patient, 50 to 100 milligrams of fentanyl and then turn it back on? So, and sometimes with these AV blocks, depending on how long it's been, as soon as you start CPR, what happens? Patient wakes up. And then you're like, oh, patient's awake. Feel pulse. As soon as you stop CPR, what happens? And you start CPR again, they wake back up. Like, oh, crap. It's probably a block. All right, so differentiation of AV blocks. Both second degrees are irregular. Type 1, you have progressively lengthening PRI, whereas they're constant in type 2. Type 1, the QRS is narrow. Type 2, they're wide. So you have 2-to-1 conduction. It could be type 1 or type 2, right? It's just that PR interval appears constant because it's a 2-to-1 block. Can be narrow or wide depending on which one it is, right? And then the third degree, QRS and the P waves are regular, but they're independent. There's no relationship between the P waves and the QRS. Can be narrow or wide depending on where that block is. Yep.
In that scenario, when you're doing like that oxygen and start pacing the people, normally you'd have the IVR established.
Yeah.
Would you do an IM and then start the pacing, or would you take time to start pacing and take time to put it?
IM's not going to be very fast, and that patient's probably going to wake up pretty quickly depending on how long they've been down. I mean, if they've been down for a while, then they might not wake up, and they've got too much, dead brain cells and heart to correctly function. Even pacing them, if they've got too much heart cells that are dead, too much ischemia there because of the low blood pressure for such a long time, then that heart, even though you're getting the conduction system and you're pacing them, is not going to squeeze because the muscle is dead. Does that make sense? So IM's not necessarily going to be quick. Normally when I do this, we give them the medication like a couple seconds before I start the button, right? But that medication needs to be there on hand. You want to start pacing them, even if they're uncomfortable, as quickly as possible, right? And then you want to get the medications on boards to make them comfortable. But it's more important that you save tissue than they have. Because it's not like you're giving them 200 joules, right?
No.
When you're pacing them, it's a much smaller current. So it's going to be, zingers, but it's not going to be jumping off the bed kind of thing. Any other questions with the AV blocks? All right, take a 5-minute break. Next, we're going to be doing chapter 6, ventricular rhythms.
I figured if it looks white,
I like it. Probably like it.
Yeah.
Probably just fall down and if I should fall in.
Right.
Yeah.
That's roughly like apex stuff, that's where.
This isn't optional, but
Because then it's propagate out the other way.
salting.
You have to pull it towards it.
How many reasonable teeth are we gonna see?